Good morning. I thank you for staying. My name is Dr. Godette, and I'm Emory University. And I'm going to be discussing the new techniques for radiation delivery in breast cancer. You know, there are a lot of things that are debatable now in breast cancer, and one of the things we're trying to do is see if there's new techniques in terms of how we deliver the radiation and the length of time we take to deliver the radiation. And again, thanks for the invitation. And in terms of disclosures, I have no disclosures. So the objective of this presentation is to understand the rationale for partial breast radiation, meaning not treating the whole breast, but treating part of the breast, which is a standard of care. There's also something called hypofractionation, and it's just like it sounds. And what I'll do is give you examples where this is being used in current practice. And lastly, we'll discuss brachytherapy and what that means and how it's being used to treat breast cancer today. So the standard of care right now for breast cancer is to treat the whole breast and ask for negative margins, and at the end of that, it's been found that that's equivalent to mastectomy. So that means the local rates of recurrence is low, the cosmesis is good, and this is the standard we use for all breast conservation. Now, you first saw the other trial, the BO4, and the BO4 was followed by NSABP06. And what they did is looked at the patients, they stratified patients to a modified radical mastectomy, and in the other patients, they had lumpectomy either with or without radiation. And this is like the gold standard from which we get the evidence to use lumpectomy and radiation instead of having to have a mastectomy. And the NSABP, what did it show? What it showed is that if you didn't give radiation, we had a low recurrence rate of almost 40%. With radiation, that dropped down to 14%, and with mastectomy, it was 5%. So you can see there's a big difference between the 40% versus the 14% with radiation. The main thing and the beauty of this was that although they got less surgery, we had the same difference. There was no difference actually in the disease-free survival, the overall survival, and the distant disease-free survival. And like I said, this is our landmark study. So the current standard of care is we treat the whole breast. We treat the breast for 5 weeks. After the 5 weeks, we boost just where the tumor was. We give an additional dose to just the tumor bed for additional 1 to 2 weeks. And the rationale for that is that if we have any residual disease, we think it will be right where the disease was. So we're not as much worried for the rest of the breast as where the disease was. And the main thing in terms of treating the whole breast, in case there's anything else that we missed within the breast, we'll be getting it within the radiation therapy portal. And this is kind of what the portal would look like. This is the patient. You're seeing it kind of outlined in the patient's skin. We're treating the whole breast. But now we do CAT scans. In the old days, we didn't have this available to us. But now in terms of the planning for the radiation, we're going to do a CAT scan of the entire breast, and in each slice we're going to outline the breast. The previous speaker spoke about the lymph nodes. We'll also be outlining the lymph nodes too on the CAT scan. And the main thing is that when we're treating the whole breast, we're also treating other organs. We're not just treating the breast. Here you can see the breast, but you can also see we're treating the ribs underneath the breast. We're treating some of the lung. And on this cut here, you could see that we're actually going to include some of the heart. And in a lot of patients, this would be a lot more than we can see right here. So the main thing is that, in the past, we felt the radiation, like I said, from NSBP06, we got the same overall survival, disease-free survival. But a meta-analysis, a recent meta-analysis, where they looked at all the patients in 78 randomized trials, they found that radiation reduced the recurrence by 2/3. And there was a slight increase, a 5% absolute reduction in the 15-year breast cancer mortality. And that was the first time that we saw that. Like I said, though, this was a meta-analysis. But the NSABP06 and the others just showed that it was the same. So what is hypofractionation? Hypofractionation is just like it sounds. Hypo means less, it's less fractions. So what are we trying to do? We're trying to give less fractions to give the equal benefit to the radiation. And historically, the larger the fraction size each day, you got an increased tissue toxicity. So it took a long time for this to catch on in the U.S. But before the U.S., we had the Wayland in Canada, and we also had studies from the UK where they had already started this practice. And as we know, which is a big thing in healthcare now, their healthcare systems there are totally different. And so they can't prolong things. Things have to be done in a timely fashion. There are a lot more people waiting to get treated than occurs here in the U.S. And like I said, in the NCIC in Canada, what they did is do a different fraction size. Here we go at 2 gray per fraction. There they went to 2.5, 2.6 gray per fraction. And what they saw, the recurrence rate was about the same, but also the cosmesis was actually very good. It wasn't much different from what we would get otherwise. In the UK, the START trial, the main thing I want you to see is they had 3 different arms. This is the standard arm we would use in the US, and these are the other 2 arms where they gave a lot higher dose per day, 3.2 and 3 gray. And again, the local relapse and the breast cosmesis was basically the same. And this is the second trial that they did. Again, this is the standard that we use here, and this is their experimental arm where they went at 2.657 per day. And again, the survival was the same, and the lack of recurrence was the same, and the cosmesis was excellent. So now we're using, from what we do standardly, we're giving bigger fractions, we're shortening the time. But how about changing the way that we treat and what we treat? When we look at most in breast recurrences, we find that most of the recurrences are going to be right where they did the lumpectomy, not on the other parts of the breast. So 85 to 90%, the recurrence is going to be right where it was. And this is from Veronese, where in Milan they actually would do like a quadrantectomy, like try to remove the larger amount of tissue because the recurrences are going to be where the cancer was. So one of the newer ways to deliver radiation is what we call accelerated partial breast radiation. Accelerated is just like it sounds, accelerated. So a shorter time to give the same value of treatment. And normally we treat patients now, like I said, we treat patients over 6 to 6.5 weeks. Now we're trying to treat patients in less than or equal to 5 days, and we're giving a higher dose of radiation per day. And partial is just like it sounds. Why treat the whole breast if the majority of the recurrence is going to be where the tumor was? Why not treat just where the tumor was? And some of the advantages of this is that if we look at studies in the US, there are many patients who do not receive radiation, both because of, a lot of times because of convenience. You know, the patient comes to me and I say you have 6 weeks of radiation and their jaw drops. And we find that many patients do not complete breast conservation because of inconvenience and accessibility. Studies show that in the US, the further the patient lives from the radiation department, the less likely they are to want to undergo breast conservation because they don't want to make a trek to the radiation department for 6.5 weeks. So hopefully this will be another way of making it more convenient for the patient and shortening the treatment time, and also reducing the cost, especially with the healthcare system that we have right now. And then you wouldn't have to wait, you know, depending on what the therapies are, sometimes you have to wait for radiation to initiate another aspect of systemic chemotherapy. Also, since we're treating less of the breast, then remember the structures I had showed you before, the ribs, the lung, and the heart. If you treat less of the breast, you're going to be treating less of those other normal structures also. So you're concentrating on the area of the highest risk and the most chance of recurrence. Some of the downsides are, of course, it's more technical, and depending on the experience of the person, that may be affected. We also have cosmesis, fibrosis, and you know, so far, the numbers don't compare to the numbers we have in the other trials. So who should be treated with this, and how can we make this happen? The main thing I want to show here, there are many different organizations, and everybody has their own idea of what is the best patient for this type of partial breast treatment. Here we can see age. You know, in breast cancer, it's felt that the younger patients tend to do worse. And so in these 2 trials, the age that they use cutoff is 45. The NSABP and RTOG, this is a current ongoing trial. So unless somebody's on trial, we wouldn't do it treat less than the whole breast because it's not standard of care in an 18-year-old. In terms of histology, we don't really do it in DCIS as often, and the tumor size, of course, has to be within 3 centimeters. In all the cases, we want the surgical margins to be negative, and we don't want any involved nodes because, again, these patients are at higher risk. Only on trial would we do that. Now, I'm a radiation oncologist, so Astro, my body has its own recommendations. So they did it into the suitable, cautionary, unsuitable. And again, age was the main factor, and mainly because a lot of the older studies did not have as many young patients. And with regards to histology, invasive lobular, they have a higher chance of failures, and DCIS, they felt it's not suitable for large DCIS patients. Again, here though, they looked at the margins, and not only negative margins, but the best patients, of course, are patients that have greater than 2 millimeters surgical margins. There are many ways to approach partial breast radiation, and this is what I'll talk about for the rest of the study. We could do it with regular radiation, or we could do it intraoperatively. And this is just a schematic of what it would look like. We're going to give external radiation from the machine. It's coming down, but it's coming from many different angles. And we're going to do it just to target just the breast tissue. And here you can see, if we use, there's something called intensity modulated radiation where we could try to decrease the side effects to the normal structure. Instead of treating the whole breast like I first showed you, here we're just treating where the cavity is and not much else. You can see there's very little lung that's being treated here and just the rib right here. Before, the whole port would have included from here all the way down to here. Veronese, again, had the Elliott trial, and what they did is they treated the patient intraoperatively. They go into the OR, they put the cone into the operative bed, and right here is a shield to protect the ribs and to deliver the radiation right into the tumor bed. I'll talk a little bit more about this later. And then the other thing I mentioned, besides operative radiation, is brachytherapy. And what brachytherapy really means is a short distance. So there's a short distance between the tumor bed and the radiation. The other radiation is what we call teletherapy. The machine is here, the patient's here. Brachytherapy, we're putting the radiation right in the middle of the tumor. And now it's being found to be just as effective as another way of delivering partial breast radiation. Again, we're reducing the treatment time. Now, this is what it looked like a little bit, when it first started. And you can see how horrific this looks. To do this to a woman, and most women, if they saw this ahead of time, would not want to have it done, first of all. And this is what it looked like in a more recent time. Here is where the tumor was. This is the tumor bed, and these are all these little buttons. These were put in by needles, and these are hollow plastic tubes. And these tubes are connected to a machine where a radioactive pellet comes out through each of these catheters and treats the patient. Not only does it look a little bit barbaric, but it takes a lot of time to do this treatment. And like I said, it would not be the most comfortable. And this is just data showing the earlier treatments that were done. And we have 2 outliers here where the local recurrence rate was high. But other than that, you could see the local recurrence is actually very low, and these patients did just as well as if we treated the whole breast. And those patients only had poor outcomes because, first of all, the margins were positive in some of those patients. Some of the patients were, they were done before the times of clips or ultrasound or CAT scan, so the right area was not always boosted. But for the most part, patients have done just as well with a limited area of treatment. Because the other technique that I showed you here, this requires a lot of experience on the part of the radiation oncologist. So what we had to do is come up with something that's a little bit more simple, or more people would be able to do. And here we have the first one that was developed, the first applicator was called Mammocyte, and really it's just an intracavitary balloon. It's simple. You don't have to know too much in terms of technique to be able to do this. And the radiation seed that we looked at before is now delivered into the center of this balloon, and the balloon is put in the tumor cavity at the time of the surgery. And what Mammocyte did is they developed many different catheters based on the anatomy of the cavity. And it's what they did is the radioactive pellet comes through the center of the balloon, and the balloon is blown up in the operative room just to fill the cavity space. And you could have many different sizes, you could have many different shapes. Later, the second one to follow that was Contura. And one of the big differences is that it has, instead of this one central balloon, there were other balloons, other channels outside of that to give the radiation. And the success of the Contour was built on the back of basically the mammocyte, and it's felt that we would get a better dose coverage. And what the balloon does is you're pushing all the healthy tissue away and just delivering the radiation just to the area that you're concerned about and sparing the rest of the breast. And here you could see those other channels that I'm talking about right here. So the first one I had showed you just had one channel in the center. This one has 4 plus the one in the center. And the beauty of this then is that you could decide to treat over here differently to over here. You don't have to have the same dose all around. You could do it however you want based on that particular patient. So we talked about the different selection criteria. We talked about the age, but the one thing we have to also have too is a specific distance from the skin surface to the actual applicator. So what we do right now is we treat the patient twice a day for 1 week, and they're done. That's a big difference when treating somebody for 6 or 7 weeks. We treat them once a day. They come at 8. They could come back, and they come back with, it has to be within 6 hours, at least 6 hours. They come back 6 hours later. They don't have to stay in the department. They're walking around. They could do whatever they want. They come back, and then they get treated. And what happens is in the operating room, under general anesthesia, at the time of the lumpectomy, now we put in what we call a spacer balloon into the cavity. It's easily done, and this is all that the patient has sticking out here, what you see. And what the surgeon does, after we get this, we wait for the pathology report. The pathology report would come like 3 to 4 days later, and this spacer balloon is swapped out for the real balloon for the treatment. It's done in the office under ultrasound. The patient then comes for radiation. We do scans, and this is what it looks like when they're attached to the machine. This is what it looks like because we have to do a CAT scan to make sure that everything's okay, and this is what the balloon would look like in the cavity. So all you're treating is the balloon and right around the balloon. And this is what the CAT scan would look like. And the main thing is, like I said, we want to make sure we have a certain amount of distance between the balloon and the skin so that we don't burn the skin. But with the other catheters that we have now, we could determine how much we want to treat at which angle. And we do a CAT scan every day before the patient's treated because we want to make sure there's no change in the balloon. It hasn't gotten smaller. There hasn't been any damage to the balloon. There's no leak or anything like that. And I take it out in the office after the last treatment. I don't have to give any local anesthesia. I just deflate the balloon and take it out. It's pretty easy. I ask them to take some pain medicine before they come in, and it's done. So in a week, they're done. And this is what it looks like 1 week later. You can't tell that the patient had any treatment. You don't have the dark pigmentation of the other radiation. And this just shows you the difference between, the local treatment in a high area versus all those needles that we would have put before to cover the tumor bed. Right now, there's not a lot of data on partial breast, especially with mammocyte was the first one that we did, but the cosmesis was excellent, and the 5-year local recurrence, again, seems to be about the same. And this is the national trial that we have right now, so we're trying to answer this question in a randomized clinical trial, which is what you do when you're trying to get an answer for any type of question in a scientific area. And what we're doing here is you're randomizing the patients to the whole breast radiation, which we know is 6 weeks, to partial breast radiation that could be done anyway. We could do it with external beam, we could do it with the mammocyte, we could stick needles in it, however we want to, just to deliver that partial breast radiation. And we're trying to see if we will get the same outcome. Now lastly, I'll talk about intraoperative radiation. So the other ones I showed you, the balloon is put in the operating room, but the radiation is delivered outside of the operating room in the radiation office. This is a way now to do intraoperative radiation, given the radiation in the OR. And this one is even better. Every time we're upping the ante. So this time you're giving the radiation right away, and then that's it. No more radiation. And the first one I'm going to talk to you about is Zoft. And this is using X-rays, and there's no radioactivity. So the beauty of this is that you don't have to have all the radiation shielding. You're doing it right there in the operating room, and then maybe even more patients may have breast conservation rather than having to, come every day. And this is just what the applicator looks like. And here are the balloons again. You see it's similar, it's just a different system. And like I said, it's a superficial system, so we don't have to have all those barriers that we would need for the other radiation treatment. And again, the cosmesis is excellent. Pain is not much, and the fat necrosis, again, is not that much. So this is limited again by the lumpectomy size, the distance from the skin again. You still have to have some distance from the skin. You don't want to deliver radiation and then burn the skin, but you could also treat some smaller breast patients. And lastly, for interop, there's something called a target trial, where they're doing targeted intraoperative radiation, and they're comparing that to the whole breast. And this is the target trial. And there's, this has been out now a couple of years, and the preliminary data looks very good. But what they did is treated the patient in an operating room, one fraction, versus treating them with external beam radiation. And what they're doing is looking to see where did the patients fail. Most of the patients, when they get radiation, even if they get radiation, they still tend to fail where the tumor was. And here again, they're looking to see where the patients fail. And this is a similar system to the linear accelerator that we use, where there's an electron accelerator and the electrons are accelerated onto the target. And then the radiation, again, it's a hollow, but it's just a different, it's a round, it's a sphere, but it's just from a different applicator. But it's doing exactly the same thing like those balloons did, which is to give the radiation in a circle in the lumpectomy cavity. And here we have many different sizes of those spheres that are going to fit in at the time of the tumor bed. So this is actually what's going into the tumor cavity at the time of the surgery. And again, what are some of the advantages? You can target the tumor bed just where it is. And now for many of the patients, the large-breasted patients, they're getting oncologic reductions at the same time. And it's difficult once they take out that tissue and put everything together to know where exactly the tumor was. But if you're in there at the same time and you're putting the applicator right there, you know exactly where you are. So it's a lot more accurate in terms of giving the radiation to the tumor bed. And then you don't have to worry as much about compliance. And they also have shielding in the operating room that you can shield the heart and the lung and protect the skin. Some of the disadvantages are, again, we don't have as long-term follow-up. For this intraoperative treatment, the patient is now under anesthesia for a lot longer, sometimes 45 minutes to an hour. But then again, at that time, after that, it's done. Also, to make sure that these patients don't have other lesions around the breast, most of those patients are going to have an MRI preoperatively where they otherwise may not have. And sometimes when you're in the operating room doing everything all at once, you try to get a frozen section and it looks like all the margins are negative, and then you may get the final section and margins are not negative. So then you have to work, then the patient will have to have additional radiation, and this will be used as a boost. So the results so far are pretty good, and that the local recurrence is only 1.5%, and at 3 and 5 years they're similar in terms of cosmesis as well as a local failure rate. And so, of course, these results it's a highly selective, like I said, the follow-up is not as long. And it may be that, we're doing it in in the low-risk patients, and that's why the results are as good. And like I said, it could be a selection bias. So in summary, whole breast radiation right now is still the standard of care. Right now, though, actually, all the associations are coming up with guidelines in terms of treating patients and in terms of making the healthcare system a better one. So for older patients, now we're asked to make sure that we offer them a shorter course of radiation, which before was not the case. So although the standard is 6 weeks, now with patients over 70, we should at least offer them a shorter course of radiation or the hypofractionation that I talked about. IMRT is another technique that can be used to decrease the dose to the surrounding structures, like we discussed. But IMRT is expensive. So if there's another way to do it, why don't we do it that way? So we have the partial breast radiation that I talked about. We have many different techniques to deliver the partial breast radiation. And so far, for the longer, the patients with the longer follow-up at 10 years, it looks like the 10-year results are the same. But of course, we're going to have the results of the randomized trial to show that that is the case. And maybe we'll get more patients who would want to undergo breast conservation, since they have a lot of options that were not necessary, that were not available to them before. Again, I thank you very much.